take care of axillary nerve, do a proper reduction, always do and suture fixation of the tuberosities, have a proper placement of plate and a screw, think about calcareous screw, see if a medial augmentation is required, and start early physiotherapy to have a successful functional shoulder for your patient. Thank you for your patient hearing.
I have one question.
Sir.
Did you experience avian of the head in type 4-3 fracture?
So most of the time avian happens when the patient had a dislocated head and coming to be neglected. And even, yeah, even in these patients, even avian happens, they do perform well.
Sir, what about deltoid attachment for flushing of the plate in the distal part? For flushing of the plate of the distal part?
So there is a part of it which actually crushes over the plate. So once you try to do it with the plate, with the longer plate, you'll be able to reach. That's not a worry.
How often do you postpone now?
Hinge, why there is more communities? But another augmentation like if you will or anything else, you suggest?
So if you have a lot of medial comminution and void, so there are two thoughts. If you have a comminution, lot of comminution, there are people who put a fibula also there. You can put the calcium also there, I mean the cement also there. But if you simply have a void of the head, you do not require to do anything.
Okay, thank you very much. I am
Thank you, sir.
requesting Professor Aravind Puri to present the test and certificate to our speaker. Next speaker is I am requesting. Okay, thank you very much. Your both topic was very interesting. Dr. Farooq Kassim.
Good afternoon, everyone. I'm going to talk on management of non-union treated by signaling without iliac bone graft. Now, there are many ways to define non-union, and like arbitrary, we could say a fracture that has not and is not going to heal. We all know these standard definitions of FDA, and there are also some pragmatic or realistic definitions that like fracture that has no potential to heal without intervention. And this is another definition by Weiss. So we all know the classifications, the types, avascular, hypervascular. So non-union of long bone fractures is a common problem in our region because many are malhandled by bone setters, inadequate fixation, and use of improper implant. Now, treatment of aseptic non-union is a challenge because it needs revitalization, revision of fixation, and filling the bone defects. The standard protocol is stable fixation with autogenous cancellous bone graft. But here we over-rim the canal and fixed with sign nail in case of closed nailing, and when we opened, we use the rimmings. Now we did harvest the rimming products from the flute of the rimmer like this, and used when we opened the fracture site, we used those rimming products, but when we did close, then we just over-rim the canal in the hope that it will concentrate in the fracture area. So there are local effects of rimming, like autografting. Their bone autograft theory is that the rimmings has got bone graft effect, and that enhances bone union. So this is a study which we did since October 2010 to December 2022 at Midford Hospital. It is a retrospective study, and we did 210 fractures of 208 patients, and which are reported in the SIGN database. But we took the patients with complete follow-up like 143, so our study sample was 143. Male were more, about 83%, and sites were almost equal. And initial fracture type, closed fractures were about 80%, and there are some open fractures as well. And fracture reduction, we reduced closed whenever possible. About 25% we could reduce closed, and open reduction rest. The surgical approaches were antegrade about 36%, and tibia, antegrade humerus, and also retrograde femur. Previous implants, when there were implant failures, were mostly non-SIGN IM nails, about 33%, and there were some plates and external fixators. We used standard SIGN nail mostly, about 85%, and there are other nails also, like SIGN fin nail, pediatric nail, and hip nail. So we, as per SIGN follow-up protocol, we arranged the results as excellent with radiological union, no infection, and painless walking, squat and smile peak for lower limb, and abduction and extension range for humerus. And satisfactory cases were with radiological union, painless walking, no infection, there's some stiffness, and in case of humerus, full abduction. And there's poor were with osteomyelitis, non-union, gross shoulder or knee stiffness. So we found healed by X-ray about 79%, and with squat and smile peaks we got 37% of the cases, and with full abduction extension range we found 19 out of 29. There was no evidence of implant breakage. So excellent were 35% and satisfactory about 60%. There are also poor results about 5%. And we have a number of complications like non-union, osteomyelitis, wound infection, and some stiffness. But there was no implant breakage. And there are some case illustrations like this case. It was a hollow nail failure. We exchanged it with SIGN nail by overreaming the canal. He is at follow-up, and this is finally he's united with full function. Another case, hollow nail failure. This is from Kumilla. I think Anwar Azim bhai will remember the case. And at first post-operative day, and he is at finally when he came to us for removal. This is another case, distal femur with nail failure. We revised it with nailing and overreaming the canal. He is at follow-up and finally united. He is amputee on the left side. And this is another case with this very distal tibia fracture with implant breakage and angulation. And this is post-op. We corrected the angle and put the nail very low so that it gives stability. And when he came finally at removal, this is another example of neglected fracture, which we did nailing with bones from the flute. He's after 2 years. And this is an example of use of improper implant. After SIGN revision, this is an L-plate failure. We fixed with the retrograde fin nail. She is at follow-up. And this is another plate failure in humerus. We nicely united with full function. Another case with plate failure of humerus. And this is bilateral femur with plate and one side canal. He is after fixation with good function and finally very much united, and he is functioning again. He is a rickshaw puller. And this is another case of hypertrophic non-union with a hollow nail. And we revised it, and this is nicely united, good function. And this case is a policeman who, with hollow nail failure. We revised it. Fracture line is still there, but he can work. So we found satisfactory result as per healing and functional state compared to other studies with iliac bone grafting. In non-union cases, sign nailing with over-reaming the canal enhances the osteogenic potential and eliminates the use of autogenous cancellous bone grafting. Thank you. Thank you very much.
I am requesting Professor R.J to present the test and the certificate to Dr. Garst. Our next speaker is Dr. Shivshankar India. Is he present?
No, sir.
Is Dr. Shivshankar present here?
No, sir.
No? Then the Vivek.
Sir. लैपटॉप ओपन करो Yes.
Yes, I am requesting our listener who are present here not to leave the session. Azim bhai, sir, কত খাবেন আসেন? Just 2 more lectures, then we will have lunch. Is everything working with the computer?
So computer okay, sir, but sir the PowerPoint is not displaying here.
এটাই ছিল
আসছে মনে হচ্ছে
So, is there any hope this will be established? একটা মেশিনে দেখেন
প্রেজেন্টেশন অলরেডি স্ক্রিনে আছে
স্ক্রিনে তো আছে ওখানে যাচ্ছে না তো তাহলে তো হবে
ওদের ইনফরমেশন
এই এই দাদা এখানে দেখো তো এখান থেকে ওখানে যাওয়া না
ভাই কি না পাওয়ার ঠিক আছে কি সমস্যা হয়েছে বলো তো
এখান থেকে প্রজেক্টরে যাচ্ছে
প্রজেকশন আছে
ওটা একটু নাড়াই দাও না ওই যে পাশে
হ্যাঁ এটা ঠিক আছে
HDMI দিছে আবার HDMI তে ঝামেলা করে
না না এটা এখানে সমস্যা না বাবু এটা তোমাদের ওই পোর্টে সমস্যা এটা কি আমারটা
আচ্ছা এটা অফ করে আবার দেন দুটো করে চালু করুন আগেরটা হলো না এই পরেরটা ওপেন হচ্ছে
প্রেজেন্টেশন ওপেন আছে স্যার।
শোনেন প্রেজেন্টেশন ওপেন হচ্ছে আপনি কি স্থানীয় বাস- এখানে তো ওপেন হচ্ছে প্রজেক্টর কাজ করছে না তো প্রবলেম তো প্রজেক্টর এগুলি আপনার কি যাচ্ছে
এই তোমরা কি ইভেন্টসের লোক নাকি ভাড়া করো লোক? এই এদিকে তাকাও।
ভাড়া ভাড়া
তুমি কি ভাড়া করো লোক নাকি জেমের লোক? এই এদিকে তাকাও। ভাড়া আসছো না? তো ফাইন।
বললাম না স্যার,
এটা সাব কন্ট্রাক্ট
সাব কন্ট্রাক্টে
এই তোমরা এদিকে একটু তাকাও। এই দুজনে একটু এদিকে তাকাও। এই দুজনে এদিকে তাকাও। ঠিক আছে।
আমি তো শোনো
এটা যাকে দেওয়া হয়েছে সে বলে ফোন দরকার এটা ফোন করতে
সমস্যা কি?
এখন সে ফোন ধরতেছে না, সকাল থেকে ফোন ধরতেছে। ওই যে আমরা ছাগল বসাইছে, এই যে একটা ছাগল আছে,
সব ভাড়া করা আছে।
বিয়ের অনুষ্ঠানে ভিডিও দেখায় বিয়ের অনুষ্ঠানে দেখে না হলুদ দেখাইতেছে প্রচুর দেখে
এই
এইবার মনে হয়
এটা ঠিক হইব না আমার কম বেবি এটা কি ঠিক হইব না ঠিক হইব না Will you like to continue without this or will you wait? Then we'll start it again after lunch.
Let's finish it.
Right?
If it is there, otherwise we'll leave it and let it go.
Oh,
I'm not going to present. I'm
no.
going.
You cannot present without this. Just sit and have a talk.
Sir, it's not a speech as such. They will see the X-rays also. Forget it. Don't worry.
Then
We'll let you go for lunch and then we stop.
Hey, Mona. Now
You can start the next session. I'm not doing.
we will start the session from after lunch from here. Because
You can start the next session.
no, next session
Unnecessary late.
no.
We will have to.
Okay, hello. Dr. Vivek. Will you please take the rest and the certificate?
স্যার 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 আসছে স্যার
No, you'll be going.
স্যার
Professor Aurobindo will present
স্যার প্রেজেন্টেশন ইজ অলরেডি
Dr. Vivek.
We'll do it. It's coming. So sorry for the delay, and I'll just finish it off. Thanks to the audio visual that we have been able to get this presentation back on the screen, and the talk is on how do we manage the distal femur fractures, and the distal femur fractures can vary from small minor fractures to major C2 C3 fractures as well. If we look at the fixation of distal femur, we need to look at the anatomy, identify the personality of the fracture, what we are dealing with, make sure that anatomically articular reduction is perfect, and then try to do biological spacing for the metaphyseal region. The crux is to maintain the limb alignment and the rotation part. And I'll just show you a few examples, now theory, of how the various fractures can be managed right now. This is an A1 fracture, which is a two-part fracture of a supracondylar area. If it is an oblique fracture, remember that many a times a nail may not work. So can a plate be working? Yes. provided that you are getting a proper primary lag screw fixation, getting an anatomical reduction of an oblique fracture, and then using it as a neutralization plate. If you bypass this or put in multiple plate screws out here, a supracondylar fracture may break, the plate may break. So remember that in a supracondylar region, you may not have that luxury. You need to have anatomical reduction with a lag screw and then a neutralization plate. Can you do a nailing? Yes, you can do a nailing in a transverse supracondylar fractures, and you can do it from a retrograde manner, and this is what it was done around 10-15 years back. A simple nail which was there at that time was used, and you can see how over time it unites, and after follow-up of 2 years you can see it is perfectly remodeled and having a great result. Nowadays there are new nails for retrograde nailing which are available in India, and I hope in Bangladesh as well, which are multi-locked and multi-planar bolts are there distally. So they give you multi-planar fixations. So if you are going to use this, remember it's very easy to reduce these fractures and use these multi-locked nails which are there from the distal multi-planar fixations. As you can see, there are multi-planed locked bolts which are there. If you come to A2 fractures also, which are having some amount of oblique comminution as well, you can be using these nails with multi-locked and multi-planar screws and get good reduction and fixation. Coming to intra-articular extensions, if the intra-articular extension is very minor and a fracture is like this in the supracondylar, how long are you going to put in the plate? So that is a problem. So you may not use the plate out here, and a simple, if you see the CT scan, the intra-articular fragment is very less minimally displaced fracture. A nail can be used here. You just hold it with a clamp, put in 2 KYs anteriorly and posteriorly, use a retrograde entry point, multiplanar screws, and you can do a long nail going up to the lesser trochanter and get anatomical good fixation, because remember it's not an articular fracture, it's a supracondylar area where the plate may not be working. World over also, the literature in 2019 suggests a retrograde nail is superior to Lis plate in fracture site deformation in a supracondylar region. Now let's come to the intra-articular, which are the real intra-articular fractures, which are having metaphyseal comminution and intra-articular fractures. So these normally we are doing it nowadays in MIPO technique or a minimally invasive. You open up the articular region, see the articular fragments, reduce them properly, slide your plate up and get the screw fixations in the top. And you can use a very long plate also with minimal amount of loss of functional outcomes in this case. In a C3 fracture, I'll show you one complex C3 fracture of a polytraumatized patient who had multiple fractures. Opposite side nailing was done and we could not fix this fracture immediately, so we put him on a fixator. At that time he had a lung injury as well. And around 2 weeks later when we went in, what we do for a complex intra-articular fracture is we need to analyze the CT scan, all views, make sure that absolute stability is there for articular component, relative stability for the metaphyseal. Look in the CT scan the displacements, where is the area which you require fixation for. Sometimes you might require a countersink headless screws for the articular fragments, and for such fractures make sure that you are having a plate which is 9 hole and above 11-13, because as long a plate with 4 screws in the diaphysis are going to give you good amount of stability. Putting in 6 screws in the diaphyseal area is not going to give you stability, it is going to make it more stiff. And sometimes you might require bone graft, but normally in the acute stages you do not. So this is that fracture which we saw in that external fixator method. You can see that on one side, on the medial side, there is a Hoffa's element. In the axial scan, you can see that the lateral and the medial side is highly comminuted. The trochlear region has got 4 or 5 pieces which you can see on the right top end of the axial. So that's what you get from the CT scan. So you might require some countersink headless screws. You need to ensure that your medial Hoffa's is taken care of and the comminution is bypassed by a long plate. So these are the things which you see on a CT scan, and that's what we did. I am fond of putting in multiple K-wires, so I put in the K-wires out here. Once the K-wire and anatomical reduction of the articular area has been done, then I have slid in the plate. Once the plate is slid, then you can go top and fix them with multiple screws. And see it in the lateral view also. Make sure that once you put in your plate, in the lateral view on the top, it is in the center. If your screws are eccentric, you will be having issues. You can see that multiple comminuted area in that clinical picture. There are at least 6 fragments of the articular which are broken in the trochlea, but all of them have been anatomically, meticulously, patiently reduced and put in with K-wires, and then subsequently the multiple screws which are there in the locking bolts have been done. And this is how you get the reduction and the fixation. The staples give you where all the incisions have been made. So the articular area has been made very open. It has to be, because the articular components has to be treated anatomically, and the rest has been 4 screws in an 11-hole plate, equidistant as possible, as far to each other as possible. And finally, once you have, you can see a single plate. Many people have that dual plate lagana, whether we won't need to put in dual plate or not. You can see with this amount, the medial callus starts throwing up within some time. You do not require a medial or a lateral dual plating for this. And this is his clinical picture after some time when he had excellent results. This is his 24 months follow-up, the opposite side nailing as well as the medial side of that plating. You can see how well the medial callus has thrown, where we did not put anything, just the biology of the nature has done its work on the medial side. And this is his final follow-up of both the sides. You can see he can sit cross-legged and has full range of motion. We do have failures, sometimes in medial side. You can see, especially in osteoporotic bones. So what to do for that nowadays? Make sure that in an osteoporotic patient, you are using a dual plate if required. You can use a dual plate with some fixation. This is a revision case for the same fracture which I showed in the previous slide. And this is the talk which I would like to say. When do you use dual implants? When you have a non-union or a failure of lateral plate. Severe medial comminution is there with medial bone, not a metaphyseal comminution I am talking of. It's the articular comminution of the medial side that you want to bypass. Very low fractures, osteoporotic fractures, above 55, 60, if you are fixing a fracture, preferably use a dual construct. And a periprosthetic fracture, nowadays the trend is for periprosthetic to use dual approaches. One fracture I'll show you. This is a fracture which we fixed. It broke after some time during COVID times, and here we used, instead of dual plating, because the plate was put very nicely, we used a nail plate construct. And this is the new thing which has come up in the world right now, and most of the elderly patients or patients where the comminution is more, this is what we are using, a nail plate construct. Nail gives you the medial strength and the medial column buttressing which is required by a plate. It gives you an alignment which is so good that you do not require a valgus or valgus problems, you do not suffer that, and the lateral fixation by the plate is also helping you in this. And this patient was fixed and taken care by a failure by a nail plate construct, and his results you can see are good enough right now. Nail plate world over is changing to nail plate construct because it is giving you the stability with less biological insult, and these are the latest papers in the last 5 years. The current management has changed in this. So where do we stand today in the present world? For extra-articular fractures, both nailing and platings can be used. For a comminuted C3 without a severe bone loss, a lateral single plate can work. With bone loss, big voids, or in osteoporotic patients, you can use a dual plate or a nail plate construct. Thank you very much.
Thank you very much. I requesting.
Go there, go there.
No, you don't. It was an excellent paper. You want to ask a question? He is having to go out. No, I say, you can ask, please. Just one.
Sir, one question.
Sure, please.
Yeah.
It's not actually a question, very impressive presentation. The communicated distal radial distal femoral fracture that you showed, normally I'm from Manchester, UK, and you showed an excellent procedure to reconstruct the anterior surface. I would have done a distal femoral replacement to make it quicker. Now the name plate got started. I do not know when it started, but I did the book in 2014 and I presented the E4 in 2017. There has been many papers since then, but I think I'm the pioneer. I started it in 2014 and it has taken over.
Yes. In fact, I would say that there is a paper in 2023 as well and 24 from UK itself, which is showing the nail plate construct. There's around 70 cases which they have presented.
I presented it in 2017,
Okay.
19 cases, and I have not put it in the paper.
No, but this is the new thing, and most of the papers have come from UK only for these nail plate constructs. Great. It's great to be with you out here.
Okay, again, thank you very much
Right.
for your excellent presentation.
What is the construct? The nail and multiple holes.
Okay, two of our speakers not present, so we have to conclude our session and welcome you for the next session after lunch. Thank you very much.
One announcement, the morning participant, you have lottery, who are the আমি বলি যে কে বিজয়ী হয়েছেন কার্ড মিলাই দেখবেন 2386 সকালে যে ওরিয়ন ফার্মাসিউটিক্যাল কোম্পানির পক্ষ থেকে আমাদের সকালে যারা আসছেন তাদের জন্য পুরস্কার লরিকাম স্যামসাং গ্যালাক্সি ট্যাব 2386 মিরালিন ইলেকট্রিক বারবিকিউ সেট 3544 মেরোম্যাক্স কারাওকে 2377 কোরাল ম্যাক্স ডিএক্স স্যান্ডউইচ মেকার 3519 ডেক্স লায়ন টি সেট 2383 আমাদের মানুষ পাইছে 2383 একটা টি সেট বাকি যারা উইনার বলে দিয়েন যে প্রাইস আছে সকালে যারা আসছিলেন ওয়েবসাইট না বলে দিলাম আপনারা লিখে নেন এটা হলো প্রাইস আছে ইয়েতে বস অফিস আছে অথবা ওরিয়ন ওরা হ্যাঁ অর্গানাইজ সেক্রেটারির কাছে থাকবে দিস ইজ দ্য পাংচুয়ালিটি রেফেল ড্র উইদিন 101 হ্যাঁ টি সেট এই আসেন মানুষ নিয়ে যাও আমি স্যার আসেন আমি স্যার দিয়ে দেন তিনটা কয়টা বাজে এখন কয়টা বাজে এখন দুইটা না আড়াইটা আধা ঘন্টা হবে না আড়াইটা ওই আমি After lunch, our next session will start 2:30 p.m. After lunch, so take hurriedly lunch, then come back again.
আমার কাছে স্যার ওটা কাজ করতে স্যার এখন এগুলো কাজ না করে গেলে স্যার আমি স্যার পরে যাচ্ছি স্যার
এক্সটেন্ড করে দিলে এই ডেস্কটপটা সব লাইভে যাচ্ছে
অফসেট করলো কামায় দিয়া প্রথম না আমার প্রথম দেখো আমার যে প্রথম কোশ্চেনটা ওসব পোস্ট নিয়ে থ্যাংক ইউ
নিয়েছি নিয়েছি